Greater Manchester is very different because it's a devolved STP area, and that means our funding is delegated from NHS England nationally, and we get to do something different with that funding. So we have 37 statutory organisations that all started to communicate together. Our strategic plan for Greater Manchester is really to decrease hospital utilisation and move care closer to the patient's home. So of course, a contract that speaks to multiple providers would fit that. We have 10 LCOs. They're like accountable care organisations, and it may be that all 10 of them will take an MCP contract. At the moment, general practice estate is a big issue. We have negative equity, we have difficult lease arrangements, and we have partners that are leaving that are owners of buildings, and they aren't able to get partners to take on the responsibility of ownership of a building. That, combined with a decrease in resource over the years and the capacity for our buildings to stay fit for purpose, has been a real issue. Our models of care may be so radically different with an MCP contract, and quite rightly they should be ambitious, so we have to make sure the estate is fit to deliver the new ambition and not the current state of play. If you are going to be fully integrated into an MCP contract, then the funding of your practice will then lie with your employer, which will be the organisation that carries that contract.
Hello, how may I help?
The other aspect is if you're going to be partially integrated with an MCP contract, then there's the potential that we're still working very closely together over hub clusters, and we might be able to do something exciting looking at what assets we already have in that partnership. Can we utilise buildings that are underutilised at the minute? So we have some lift buildings that are underutilised, we have some police stations, we have fire stations. It's driven us to talk and communicate in a way that we've never done before as practitioners and providers. So therefore we can either share estates or we can work on solutions together instead of just being our individual bespoke practices. People often suggest to me that providing general practice at scale means job losses. In my opinion, there isn't enough workforce at the current time anyway, and what we're going to do is change the workforce rather than lose it. So for an example, back office, which people call your practice manager or some of the administrators that work in a practice, they could be specialised in different ways. So some would stay with the core management of general practice, and others can have special interests where they manage speciality teams, some that specialise in business planning and producing business documents. So we really need them all. At the moment in general practice, we don't utilise information technology in the most useful way currently. So we really want to do something in this area using this type of contract to enable us. IT in terms of sharing records and sharing data with widely integrated teams. We really need to drive more data into our practices in terms of business intelligence as well. So that will help us to see where the gaps are in provision and fill them by the right service or the right workforce. I personally am really positive about the MCP contract and some of the opportunities it allows us to integrate with a team, with the GP having influence over the partners that are part of that contract style. It also gives us opportunities to be regulated in a different way and to provide healthcare in a different way, with some specialisms that allow for resilience of the GP workforce and career progression. They're great advantages of the MCP.